Thanks, Jens. We're down to the hardcore VQI enthusiasts. Let's see. Thank you for the opportunity to present. I'm going to give you some background about the ICVR if you've not heard of this, and then talk to you about a specific project that we have ongoing now. This is the first meeting of the ICVR in 2014. There are a number of people in this room that were at that meeting, along with some folks from the FDA and industry. And since that time, the ICVR has become a much larger organization. What it is essentially a collaboration between the VQI and VascuNet, our sister organization, which is in Europe and Australasia. It includes 27 national and regional registries from around Europe, Australia, New Zealand, and even in South America, Brazil, and Singapore. And within that group, we have a number of ongoing projects. We have biannual meetings. We, during COVID, switched to hybrid meetings, but had our first meeting in person again in Granada, Spain, just last month, which was still hybrid, but there were some of my U.S. counterparts there. But we talk about our ongoing projects, future projects, quality improvement initiatives that we're doing internationally. I'm not going to go through all of these, but we have a lot of foundational work that we've done over the last few years. We have a number of projects looking at hospital volume, failure to rescue, optimal volume outcome relationships. We have some ongoing quality initiatives looking at patient-reported outcomes. Danny Burgess is helping with this transatlantic effort that is in collaboration with something that we're also doing isolated to the VQI. Disparities in care, a number of things. What I'm going to talk to you about today is this particular project. This is a project looking at ruptured AAA and the use of EVAR. And the intention of this was to test our internal collaboration and see if we could use our ICVR data to support regulatory decision-making within the U.S. So just a little bit of background, although I'm sure you all know that EVAR is used very frequently for ruptured aneurysms, the current EVAR device labeling of all devices specifically say that they do not include or have not been tested in ruptured aneurysms. So we looked at our practice patterns in the ICVR, and this is a paper that we published in Circulation a couple years ago, looking at over 50,000 AAA repairs, and there were some interesting variations across the ICVR and within individual countries. But if you look at this is a chart of ruptured aneurysms across the participating countries at the time, and what's interesting is that it varies from down less than 10% of aneurysms that are ruptured treated with EVAR in Denmark to above 50% in the United States, and there's some interesting trends that are related to reimbursement models in those countries that I won't go into, but suffice it to say that there's a lot of variation across the ICVR. This may not project that well, but what this shows is the individual countries have a tremendous amount of variation within the countries. Each of those little circles in the columns is an individual center, and the larger the circle, the more the number of cases, and on the left is the percentage. So some centers treat ruptured aneurysm nearly 100% of the time with EVAR, and some do it nearly never. So we know that there's extreme variation in practice, and we thought that real-world evidence from registries would be essential to determine the performance of EVAR in ruptured aneurysm, and we thought we would leverage these data that we have. And the central question of this really is, can we alter a label based on real-world international registry data? And this has never been done before. This was in collaboration with the International Medical Device Regulatory Forum and the FDA and industry partners. We went through the IDE submission project, and this does have an IDE number with the FDA. There's a couple of labels to show you here that this is the Endurant label that specifically says it's not been evaluated with rupture. This is Endologic, same thing. All of the devices say the same. This is intended to be a proof of concept, as I said. Until we actually have a label change, we haven't really demonstrated that, but what we have demonstrated is that we can collect the data and demonstrate what we intended to demonstrate. Foundational to the project was a power analysis and determining how many cases we needed. So we looked at 8 centers to almost 2,900 cases and found that their mortality was about 20% with EVAR. At the same hospitals, the in-hospital mortality after open was 31%, and we determined that we would need, in aggregate, 161 EVAR patients to determine the endpoint that we sought to determine. We developed our performance goals based on historical data from the VQI that was from 2016 to 19, and we ultimately intended to evaluate 30 devices per country. We harmonized our variables. This may not seem like a big deal, but harmonizing your variables across 28 countries is not really that easy, but we did it. We had a hard primary endpoint, which was in-hospital mortality. Our secondary endpoints are listed here: cardiac, respiratory, renal, and so forth. The FDA requested that we had 50% of patients from the VQI, and our data analysis was to be done at Weill Cornell at the MD EpiNet Center, and we decided on the front end that we would not do head-to-head device comparison. These 4 companies were involved at the outset, and we collected data for those devices. We developed an app which was used for data collection outside of the VQI. Mostly this was used in Europe. The data in Europe was actually collected in Hamburg, Germany, and analyzed there and then sent to us in de-identified fashion for analysis at Cornell, and we used a different analyst to analyze the data in a de-identified fashion than the analyst that saw the identified data. So these are the cases that we ended up with. We had to oversample in some of the registries. They were allocated their number of patients based on their historical performance of EVAR at each individual center and in each individual registry. And so some of these registries only supplied us with 2 or 3 or 5 cases, and some may have supplied us with 20. And so they may use a lot of Medtronic and not Gore, for example. So we had to oversample. We ended up with 219 patients. This is a breakdown in VascuNet and VQI. You can see on the right side, those are each of those individual 4 devices. So this is what we came up with. These are demographics in these patients, open versus EVAR. We found that the EVAR patients were older on average than the open cohort and had a larger diameter aneurysm, and otherwise were very similar. Our outcomes, we had a higher rate of bowel ischemia and acute compartment syndrome and hemorrhage return to the OR with open AAA, not surprisingly. And this is the kind of the crux of the whole thing. This is our in-hospital mortality. That red line is the performance goals set by the open AAA cohort, and our EVAR cohort was 18%. So we met our performance goal with the aggregate data. So what we've demonstrated is that multinational device data can be successfully collected and evaluated for device performance, which is something that has not been previously done before, but what we really want to do next is have a successful label change. We have shown these data to the companies that have financially supported the project, and the next step will be for them to actually take their data to FDA for label change. Thank you.
So, Adam, one of the obstacles that you faced was, of course, the increased data restrictions coming out of Europe. Do you want to talk about that at all and the impact it had on this project?
Yeah, and I didn't go into that because of the time, but that was one of the major hurdles that actually delayed us for a little over a year, actually, because there were some changes in the laws across Europe called GDPR that essentially created the situation where we had to collect our data at one site in Hamburg, and we had to go through a tremendous, we meaning the folks mostly in Hamburg, had to go through a tremendous amount of work to demonstrate to GDPR that we were compliant with their laws, and that the data that was shared with us was unidentifiable data. So that actually will make our next project, hopefully we'll have much easier, because we'll have already hurdled that particular issue.
The European data privacy regulations have become quite a bit more strict, and traditionally the coverage evidence decisions for products in Europe were relatively lax compared to ours, but they have also become much more strict, and they're going to be they want to use real-world evidence again to get coverage evidence decisions for medical devices in Europe, and are actually using VQI data for that regulatory guidance. Question?
Challenges with harmonizing across the 28 countries, did that point to any changes that we should be considering in our VQI modules on our end of the definitions?
I'm sorry, Emily, I can barely hear you. What was the...
Across the variables that had to be harmonized, did that point to any variables within VQI that we should be reconsidering our definitions for in that process?
I'd still only heard part of that.
I think it was related to data harmonization, whether you had to modify VQI definitions.
No, actually, good question. So we did not. We mostly there were some registries that were already fairly close to VQI, and then there were a number that really it was mostly adding variables in a lot of the registries rather than altering the variables. I would say the majority of the changes were done in Europe, not in the VQI. In fact, we didn't have to add anything in the VQI. We're pretty comprehensive.
Terrific. Thank you very much.
All right, thank you.